We'll give everyone just a minute to join and then I'll introduce you and we'll get started. Okay, we'll go ahead and get started. Welcome everybody. My name is Julie Harrison. I am moderating today's session. I'll be providing the CEU code for you at the end. Before we get started, please remember to mute yourself. And if you have questions throughout the session, you can go ahead and put them in the chat. We'll save some time for them at the end. And without further ado, I would go ahead and introduce Teresa Plummer and Heather Feldner. They're going to be your speakers today. I'll turn it over to you two.
Thank you, Julie.
Yeah, thanks so much, Julie. And thank you all for attending the session today. My name is Heather Feldner. I am an assistant professor in the Department of Rehabilitation Medicine at the University of Washington. I'm also on the core faculty of the Disability Studies program there and an associate director of a new center we have on campus called Center for Research and Education on Accessible Technology and Experiences, known as CREATE. I am a white woman with a short gray and brown hair. I'm wearing dark rimmed glasses and a white tunic shirt with some black geometric print on it. And in the background today is my purple University of Washington screen. I use she, her pronouns, and I do not identify as having a disability, though I am a caregiver of individuals with disabilities. So that both limits and shapes the perspectives that I bring to the session today. I'll turn it over to Teresa.
Thanks, Heather. Yes, my name is Teresa Plummer. I am an associate professor in the School of Occupational Therapy at Belmont University in Nashville, sunny Nashville, in the United States. I am also a female. My hair is dark reddish brown, and I am a white female, and I am currently wearing a blue sweater, and I identify as she, her. And we will be introducing Alyson. Heather, do you want to introduce Alyson now?
Sure, absolutely, yeah. So our third co-presenter and project collaborator who couldn't be here today is Alyson Hendry. She is a speech language pathologist in the Cherry Creek Public Schools in Denver, Colorado, and also owns her own business called Speech and Movement. And we'll hear from her via video a little bit later in our presentation today, but we're so thrilled to have an interdisciplinary team that has been engaged in this project. So our learning objectives for today, after the session, participants will be able to identify 3 developmental or social benefits of powered mobility devices for infants and toddlers with disabilities. Discuss 2 reasons that more rigorous approaches to powered mobility introduction are beneficial to both clinicians and caregivers. 3, understand that purpose of and parameters for introduction of the Permobil Explore Mini within the evidence-based guideline consensus document that we'll be talking about today, and identify 1 way in which an evidence-based guideline for the introduction of powered mobility for infants can support future research and clinical work. And in terms of our disclosures, funding for this research project was provided by Permobil. Teresa, I'll pass it on to you.
Okay, thank you, Alyson. I mean, Heather, you know, when you work with a team like this, we just get so enmeshed in one another. So as we were thinking about developing that guideline, we first thought about the key aspects of development to help us kind of shape what we were doing and to provide the taxonomy with the categories that we were thinking about. And so those 5 domains include cognition, language and communication, social and emotional, motor, and sensory awareness. And so we felt like it was a very appropriate way to base our information based on this taxonomy. Next slide, please. So we already know that there have been many studies supporting the benefits of these categories, these domains. This is just a small sample of the many research studies that support that there have been developmental benefits associated with each of those domains, including cognition, language, social participation, independence, and sensory. Next slide, please. One thing we don't have a lot of information about, and I think it's probably because, we're talking about infants and infants who are moving into toddler. And that is this whole sense of agency and this whole sense of children being their own change agent. So this is more of the psychosocial dynamic of what happens when a child has choice, what happens when a child can make decisions for themselves. And so this slide that illustrates that children are their own change agent, meaning that when they make an action, it causes a reaction. And so that facilitates and maintains change. And so that begins at the very first moment of life. And so every action that again creates a reaction increases broader and broader skill sets for the child. So in terms of how this develops, how a child really develops a sense of agency, we think about any other trajectory of development. Starts personal, right? So they're able to have some agency over themselves, and then begins to be peripersonal, meaning just beyond their reach, like this little girl is illustrating as she travels around the world. And then extrapersonal, meaning community. Next slide, please. And so the sense of control that a child has leads to social participation. And that's an important feature when we consider pediatric powered mobility, and really when we consider power mobility in general, is that it's not just the, as many people say, not just the idea of going from point A to point B, but what is it you're going to do when you get there? What is it that interests you? What is it that captivates you? And so this sense of being able to develop autonomy and agency then leads to the ability to be engaged in one's community. And that's an important feature of pediatric power mobility, and one that begins with self-agency and self-autonomy. Next.
And so now we're going to hear for the first time from our collaborator, Alyson.
Hi, I'm Alyson Hendry, pediatric speech language pathologist, and I have been honored to be a part of the development of this protocol. As a speech language pathologist, having worked on a number of interdisciplinary teams, I personally and professionally acknowledge the benefits of working collectively, collaboratively, and learning from one another. We are not the first interdisciplinary team to research early powered mobility. We looked to pioneers like Teft, Forumasu, and Goret, and their prolific work has laid foundation for research and intervention in the area of early pediatric powered mobility. But we have not seen a multidisciplinary approach commonly replicated in the subsequent literature on early powered mobility. Because of the connection between early mobility and early communication development, we sought out to create a contemporary interdisciplinary team, seeking input from PTs, OTs, and SLPs all over the world to ensure representation and expertise, both in the empirical research as well as the clinical experience. It's important to include a speech language pathologist on this team because of the well-established research of early motor development being directly tied to early language development. Developmentally, motor skills often precede communication because as we become explorers in our environments, we begin to engage more meaningfully with our surroundings and with people in our environments, which fosters social and communication interaction and development. Children who have delays in early motor development consequently also often have delays in communication, and speech and language disorders commonly accompany or result from many conditions that also interfere with motor development, such as Down syndrome, cerebral palsy, Fragile X, autism spectrum disorders, TBI, and more. Numerous studies have shown that use of powered mobility positively impacts development in a variety of areas, including cognitive, visual, language, social, and psychological abilities. Because of the developmental importance of mobility and the reciprocal learning that often occurs during mobility and the interaction with people in the environment, researchers have recommended that powered mobility be considered as part of a comprehensive early intervention program. Motor development not only impacts the social side of communication and creates opportunities to practice language, but it also impacts motor and sensory skills necessary for speech production for both pre and nonverbal children. For example, Iverson and Focaroli explained that mouthing is how a child begins to learn and understand their environment, as well as it provides input to the mouth to help with formation and motor development of early consonants and vowels. Mouthing is especially important for children who are not fed by mouth, who are not getting that regular oral input. So exploring their environment allows them greater exposure to more items to mouth, which fosters understanding and cognitive development of their surroundings, as well as provides oral input to stimulate oral sensations and oral motor patterns, which are important for feeding and producing speech sounds. We know that early exploration is paramount to development of the cognitive, linguistic, and social development, as well as the motor production for speech. Without exploration, children are at greater risk of delays in those areas. Providing opportunities for a child in and around a powered mobility device allows for novel experiences and novel environments with greater exposure to new opportunities, items, and chances to problem solve, which are all opportunities for developing language skills. But even without all those other benefits, simply learning how to use a powered mobility device offers endless opportunities for unique language and communication growth while using the device and by following the child's lead, such as practicing the skills of following 1 to 2 step directions, using language for a variety of purposes like requesting or denying, commenting, and also making eye contact. Socially, a child may experience a range of emotions when they're exploring the device, which is a special opportunity for the social and emotional engagement and development with both caregivers and clinicians.
So why a guideline for introduction of power for this particular age and stage? Well, first and foremost, because deciding how and when and where to introduce powered mobility is really a high stakes decision for both families and clinicians. There are financial implications, there are social implications, there are environmental access implications. And so anything that can really help support this process of introduction in a population that just more recently has been considered as potential drivers, that's really important. Also, I think the time is right. Teresa mentioned in the introduction that we are building this body of evidence from a lot of different disciplines. And we now have really wonderful theory and descriptors of learning stages, facilitating strategies, training assessment tools. And these are all available, but they really haven't yet been widely synthesized and brought together with information from additional disciplines. And so that was something that we thought was a really unique opportunity to do. And, when we think about our practice in the clinics, there really isn't a great way to standardize how we teach or introduce infants or young children to use powered mobility devices, as well as evaluate outcomes across multidisciplinary domains. And this especially comes into play if a device is going to be used for short term or temporarily, or in addition to other types of motor intervention strategies. And so we thought that was that really set the stage to do the work that we're presenting to you today. And we thought that having an evidence-based guideline for powered mobility introduction for this age and stage was really crucial because it can also serve to improve access to mobility as part of a multimodal early intervention strategy, as I mentioned. I also think that it's just the next cog in the interconnected gear of what we all are trying to do, which is improve evidence and share decision making and support participation and engagement for all children across the lifespan. And so I think this is, again, just that next step, and we hope that it continues to be built upon in the future. This guideline can also help to provide reproducible, repetitive, and reliable training that can facilitate learning across contexts and help to potentially standardize some of that introduction so we can measure our outcomes better. And, as we mentioned, our colleagues have just been amazing pioneers in developing tools and metrics and systems and strategies that can help us to really pinpoint how mobility intervention is effective and in which domains, those developmental domains that Teresa mentioned earlier. Finally, something like this, a guideline, we also feel like it can really support future research and future grant funding and multi-site studies to get that big data that we need to really support the work that we do. And again, especially with those really young ages where some people might be unsure of the benefits. We know it's great, and hopefully this getting this information synthesized and out there can really help maximize mobility and exploration outcomes for young children with disabilities. Another reason why we think the time is right is the Explorer Mini has just been released in the last few years, and this is a really unique opportunity to focus in on children in this early age and developmental stage, and this time when all of this learning is happening around us. We've got these strong theoretical support for training strategies, and we didn't always have these, or we didn't always apply a multidisciplinary approach to using these with powered mobility introduction. So again, a huge shout out to the pioneers that have really helped to support the development of this guideline through their work and their expertise and in developing some of that theory and some of that practice. The timing of the release of the Explorer Mini was fantastic for this particular project, but we also wanted to ensure that the guideline that we were putting together was intended for not only the Explorer Mini, but also other devices and devices that may be designed in the future too. And so we really tried to look broadly and globally at the work that we could do in this guide. So part of our development, one of the first things that we did when we embarked on this project was to conduct an extensive literature review. And again, this included a baseline team of an occupational, a physical, and a speech language pathologist. But we went broadly beyond that. And we know really seminal powered mobility work has been done across numerous fields. And we wanted to really reach out and include all of that in our preparatory activities. And so we looked at neurology, we looked at psychology, child development, early childhood education, even ophthalmology in terms of some of the visual spatial changes that happen with self-initiated movement. And so that was very intentional, as was our involvement of Teresa, Alyson, and myself representing different fields. And you heard from Alyson, the direct connection there between mobility, communication, learning. It's so important, and we want to build off of the work that Tef from Masun had begun, a couple decades ago now, and continue to do work in this day. The other thing that we really wanted to do was make sure that we were representing feedback from experts. And so we included an expert review panel in our process as well, which I'll explain a little bit more down the road. After we engaged in the literature review, one of the main things that we did as a part of this project is a Delphi consensus study. And this is a great tool to obtain opinions from experts in one or in many groups. And in this study, we as researchers served as facilitators to obtain this really individualized and anonymized assessment from each of our participants. It is a slower research process. There's a figure on the screen that shows this kind of cyclical process between our experts and our facilitator. And we did go through multiple rounds of data collection and collation of responses in between each round. But again, that was very intentional to make sure that we were representing the experiences and the expertise of our stakeholder groups, in addition to all of the literature that we had brought forth for this project. One of the nice things about this kind of cyclical feedback loop is that it gave our experts a chance to agree with or disagree with opinions and experiences that were being stated. They could also contribute open-ended responses and then refine those responses in subsequent rounds. So it really was kind of a deep thinking exercise for our stakeholders, which was great. Once the stakeholders went through the different rounds, we were able to compile their responses, include those in our draft documents, and send them back to our participants to make sure that we were interpreting things correctly and making sure that we were honoring the opinions and the experiences that were brought forth by our stakeholder groups. And so they were really essential in shaping the data that went into creating this guideline. And we had a fantastic group of stakeholders. And this was something that we just were so grateful for in the process. We had 40 participants throughout the different rounds of our study. And that was just really wonderful because not only did we get international representation across 6 different countries, but we also got representation from across disciplines and including caregivers. And that was a really central and important part for all of us. And so you can see from this slide here, 18 OTs, 12 PTs, 7 SLPs, and 3 caregivers, in addition to the international distribution. So we really had a wide variety of voices as stakeholders in this process. So Delphi studies can have a number of different rounds where questions are presented and information is shared or acted upon. And for our particular study, we had 3 Delphi rounds. Round 1 consisted of, it was an open-ended inquiry. And within that round, we asked our stakeholders to identify instructional strategies that they felt were beneficial for the introduction of power mobility. And also we asked our stakeholders to categorize responses and experiences and ideas across those 5 developmental domains that Teresa introduced earlier. So that was our first round. We took all of the responses, those open-ended responses, we consolidated them into more of a list structure. And then in round 2, what we did was we provided the participants with a list of summary statements that were gathered from that first round. And we did this to establish consensus as to which statements were considered essential or most important in our stakeholders' views. And once we had the information about what our stakeholders thought was most important, we went back to our evidence base and we looked at all of the evidence across all of the fields to determine whether or not there was or was not evidence to support the essential statements from our responses. After that point, we went into the round 3 of the Delphi, in which we created a draft guideline, and that was developed based on a threshold of 75% consensus and the evidence appraisal that went with it. And then we shared out that guideline, that initial draft, with our participants. And again, here we asked for agreement about whether or not the meaningful statements from round 2 were represented in the guide. And then we also asked for open-ended responses, what needed to be changed, what needed to be added. We asked people to comment on the clarity, on the content. And this was really important for us as the final round, because then we took all of that feedback and we were able to redraft the guideline based on that final round. And so Teresa is going to introduce the round 1 here.
Thank you, Heather. So yes, round 1 included the 40 participants, and they gave us just open-ended comments, as Heather stated. And they really, and we'll go through some of the other comments they made, but they fell across about 10 different general categories. And that was, what are the prerequisites of a child that they felt like we needed caregiver support and training, that the environment needed to be supportive. We have to ensure safety, provide opportunities for agency and self-direction, and that we incorporate focused teaching and learning strategies, use a play-based approach, and then have an appropriate device. And then we talked about the trainer categories. And so next slide, please. If you look at this, so the question was, what are the essential characteristics of power mobility training for infants and toddlers 12 to 36 months? That was our first question. And so some of the things that people wrote were things like, I've noticed that when they find they can move independently, it increases their motivation. It's been a combination of switch activated movement and or use of power mobility, and it should be play-based and motivational. So we took all of these comments from the 40 individuals and coded them according to themes. So one of the things we found to be very interesting is that there was a really a de-emphasis on the readiness of a child being ready for power mobility, and really more on the concept of self-exploration. Next slide, please. So the other part of this first round was we asked them what were the essential considerations across developmental domains, because as we stated before, we know those are the categories of development, and that's some of the evidence we currently have. Is it changes language, it changes posture, it changes these things. So we wanted to know specifically what were these considerations that we should take in, that we should understand. Next.
So for our round two, we had 22 participants, and what we did was we took those statements that were generated that Teresa just mentioned. We took the ones that had met the threshold for consensus, and so out of the 69 statements or on the essential elements from round one, 57 out of 69 of those statements met the greater than 75% consensus. And that is a combination of items that were strongly agreed with or strongly disagreed with. And so both of those we thought were important in terms of how we kind of went about creating this guide. The 12 out of there were 12 out of 69 statements that did not meet the 75% agreement threshold. And those statements were considered, but largely left out of the guide, because the whole purpose was to really combine this, our evidence base and our expert consensus. And so I'll just share some examples of those with you now. There were several statements that actually had 100% agreement across all participants. Examples of those include, it is important for caregivers and other care providers and clinicians to collaborate and set realistic expectations about learning. It's important to allow child exercise choice during training sessions. It's important to encourage frequent and flexible opportunities to use the device during training. It's important that the child feels safe while using the device. It's important for the environment to safely allow more self-directed exploration. It is important that the child learn through exploration, and it is important that training be fun and play-based. And so these were the statements that, again, it was no question in both the evidence and our expert consensus, 100% agreement was reached on these. And so this was a core part of how we formatted our guide. There's also some disagreement statements. These are statements that were initially presented as it is important to, and because the disagreement was higher than 75%, we actually wound up including these into the guide, but flipping the language a little bit so that we made it very clear that it was not important to do these things. So for example, the statement became, it is not important for the child to have specific abilities such as language, vision, cognition, or cause and effect prior to beginning training. It is not important to provide vestibular movement activities into the child's therapy program before introducing the device. It is not important for the child to engage in a wheelchair skills program as part of training with the mobility device. And so again, because these statements achieved disagreement consensus greater than 75%, they were also included with the guide and combined with the evidence to support the statements. As I mentioned, there was not consensus on 12 out of the 69 statements. Here are some. And while these may be very situationally appropriate and important, they were not explicitly included in the guide as expert consensus statements. There were some aspects of some of these items that did get included as a result of evidence appraisal, but there was some, there was not consensus in terms of, whether or not to use physical prompts or to engage in reaching activities or to engage in messy play, for example. So what happened when we went back to the evidence? Again, this was a really important part of what we wanted to try and do as we were synthesizing all of these different facets of this project. And we really wanted to make sure that we were being true to the evidence and to the expert consensus. So for example, there's a statement that did achieve consensus. It is important that caregivers and clinicians take immediate steps to remedy an issue with the child, posture, power mobility device, controls, or the environment that may limit success. So this was the statement that did achieve consensus. However, when we went back to the evidence, we actually found that the evidence supported not intervening immediately, rather waiting to see how the child might respond to an environment or a situation in which they needed to make a postural adjustment, or, say they drove and they, bumped into the wall and couldn't make the device move. The evidence actually said, it's okay not to intervene immediately as long as their direct safety is not of concern. Rather, that a delayed response might provide assistance to help solve the problem or to help a learning process occur where the child was actually in charge of figuring out some sort of solution, right? So for this example, this was a statement that did achieve consensus, but did not have the evidence to support it. So I'll show you how we address that in our guide. We wanted to honor consensus and as well as clinical and parental judgment, but we also wanted to highlight that fell out of alignment with the current evidence. And, recognizing that our field's evidence base is really new and is going to continue to evolve over time and be added to, we thought it was important to really kind of make that distinction. And so how we handle that in the guide is we addressed that through the following. We would say something like, though consensus was reached that, and then insert the statement, current evidence does not support this statement, instead indicating, and then we'd present the evidence. And so we thought that was a way to honor the expertise of our panelists, but also to make it very clear that the current evidence was not aligned with that statement. So that's how we handled that as we continued to develop the guide. And so after that second round, as we mentioned, we went back and did a really thorough search of all of the literature to determine whether or not there was empirical or theoretical support. And I just mentioned how we addressed the disagreement. And we really, took our time with this. There was a fairly significant gap in between rounds 2 and 3. And part of it was that we really wanted to make sure that we were exhausting all of our opportunities to review the literature and to make sure that we were making it clear when those were in alignment and when those weren't. So again, in addition to kind of dealing with those discordant statements, We also continued to bring in a lot of more additional information from language communication, vision, cognitive components, that sort of thing. And we really, again, our goal was to make this a very integrated and synthesized document that really recognized all of the work that has come before it in our field. And Teresa, I'm going to jump in for round 3. Sorry.
Yep. Thanks, Heather. So the third round of the Delphi study, we took the statements that were the agreed upon statements that Heather just introduced. We sent them back to the Delphi group. And at this point, we had 20 participants. There were 8 OTs, 9 PTs, and 2 SLPs. So of course, probably, situations of studies like Delphi and PAR studies tend to have some attrition. It's because they are kind of a longer lasting. So it was not surprising, but we were certainly grateful to have still 50% of our participants remained in this study. And so what we did was we asked them to take a look at this guideline and ask what we put in this guideline, does that represent what you meant, right? Does everything that's in this guideline something you had said or something somebody else had said? And the other question we ask it was just an open-ended question. So what do you think? Is this usable? Do you think something needs edited? Of course, we felt we did a pretty good job organizing it, but little did we know that other people didn't think so. No, honestly, the feedback we got from other individuals was so helpful to help us understand that, well, in this country, we might do it this way. In this environment, we might do this. And so again, with Delphi studies, you take feedback from all directions and you make changes to it. And that's what this iterative process of a Delphi study is all about, is taking the feedback from your stakeholders, making changes as they request, and then sending it back out. So the data, next slide, please. The data that Delphi round 3 looked like was this. And so we would ask the question, does this statement, family buy-in and motivation are important in order to continue supporting, et cetera, et cetera. And do you see that this statement is reflected in the guide? Yes or no? And so what we have here is a great amount of agreement with all of our statements. We ended up not removing any statement that was in there. And we had really terrific feedback when it came to the representation of it. Next slide. On the other hand, the feedback we received about the organization of it was, well, the use of APA is really hard. So because we had 140 citations, adding all those names at the end of a sentence was really difficult to read. And so that was so fun. I mean, like if you've never done APA to AMA, station changing, you have missed the bulk of fun that one can have as an academic person or a researcher. It's tons of fun. So the feedback we did receive was related to the restructuring in the order of content, which once we did that, we're like, oh, well, that does make so much sense. Remove redundancies because we had stated some things that were particular to the domains. And so it did look a little bulky. And then, as I said, the citation style, which I was so grateful for the opportunity to spend so much time doing that and really hone my skills. And then, of course, provide a table of contents, which we did, and then clarify, adding clarity for the different types of learning stages and phases, which we'll show you as in the guide itself. Heather, back to you.
Thank you. So one of the things that actually came out of the feedback that we received, which again was just so valuable, because when you're in the midst of this project, right, you get lost, you can't see the forest through the trees. We wanted to, again, make sure that we weren't necessarily speaking from just our little project group point of view, but that we really represented not only our stakeholders that included caregivers, but folks that are considered experts in the field. And so we engaged 4 people as paid experts to do a final review and comment once we did the redraft and incorporated all of the feedback that our stakeholders had given us from the Delphi study. And we to kind of systematize this feedback, we generated a series of questions. So we wanted to know from our reviewers, are we true to current powered mobility knowledge? Have we represented and cited the works of our colleagues accurately? What do you see as the utility of this guideline? Is the guideline culturally relevant, sensitive? Is it adaptable to different international locations and considerations in terms of infrastructure and environment and the way funding works, et cetera? How can we make the guideline more clear and complete? And then finally, we asked our expert reviewers for open-ended feedback. How else can we improve this? Given here's what we've done so far, how else can we elevate this to really make it a powerful tool to be used by families, by clinicians, and by caregivers? Or I'm sorry, researchers, families and caregivers, clinicians and researchers. And so after that process and throughout that process, we were able to produce 3 different versions of a guideline for introduction of powered mobility for infants and toddlers. The first was the main document that we worked off of, where all of the evidence was included, all of the stakeholder perspectives, all of the different interdisciplinary facets. So this is all of the content. It's definitely the most dense, and not only with the evidence, but also with practical strategies for clinicians and researchers that, generally tend to be well-versed in our field, right? Anyone on this call probably could jump immediately to this comprehensive guideline. We also thought it was really important to reach clinicians who may be new to this area, or who want to learn more, or families, right? And so there is in development right now a clinical version, which has a lot of the content, but it's structured for more novice or intermediate clinicians that do want to elevate their practice to systematically introduce powered mobility in collaborative partnership with families. And then we also have a family version that's available, and that still has quite a bit of content in it, but it's structured to provide really family-friendly and simple information to assist families in making those tough decisions, or in making them, reassured that they're making the right decision about introducing powered mobility, and talking about different ways to access different environments, whether that's home, whether that's in the community, and also a little bit of information about, learner stage as well. And so we're very, very excited to, after this whole process over the last 1.5 years or so, just wanted to share a few highlights with you all today. So in addition to the multiple different versions that I just spoke about, the guideline also incorporates both in-device and out-of-device approaches based on evidence. It is, again, a synthesis of current work, really seminal work by Elizabeth Nilsson, Josephine Durkin, Debbie Field, Roz Livingstone, et cetera, et cetera, et cetera, in terms of learner stage and phase descriptions. And again, it synthesizes a ton of additional resources from sensory communication and language literature and strategies that really kind of go along with and are embedded throughout the entire structure of the guideline. As Teresa mentioned, there's nearly 140 references and 3 full appendices for further learning that specifically target language and communication as well. And so our table of contents, just to kind of give you an outline, we do spend some time talking about the background and the purpose, much of which we've shared with you today as terms of why this is important and how we can synthesize these different sources at this point. We talk about evidence appraisal, we talk about our expert consensus, the synthesis of existing work, as well as the multidisciplinary focus. We do spend a good amount of time talking about ability considerations, not quote unquote readiness per se, because again, there was that that consensus that that we're probably all at in this Zoom room, that focusing more on exploration, especially in these early ages and stages, rather than hard defined readiness skills. We address the question of dosage, right? This idea of whether or not a child is investigating early powered mobility, or on-time powered mobility, as part of a more comprehensive mobility intervention plan, right? One that includes motor skill development, one that includes the use of technology. Traditionally, kids hadn't been thought about as part-time mobility technology users, right? It's this either or. And so we talk about that. We talk about what literature exists in terms of, some of the RCTs that have been done with power mobility. What was the dosage like in those studies? What do other studies say in terms of dosage and frequency? Again, we spend some time on communication and language, and Alyson's going to jump back in here in a bit to provide some additional information on that. We talk about the learning stages, and then we have a summary of intervention techniques that include safety, preparatory considerations, as well as device setup, device use, and feedback and cueing for each of the early, intermediate, and advanced learning stages. Again, with our really young kids, we don't necessarily expect that they're going to be at an advanced stage of learning when it comes to introducing power. But we wanted, for completeness sake, to at least touch on those in this document. And so here are a few snapshots from the guideline. On the left is part of our safety and preparation. And so it just, again, it's colorful. It's meant to draw in a lot of different stakeholders, from families all the way up to researchers. On the right is just a snapshot in terms of the early and intermediate learning stages and some of the real specific tools and strategies that it provides. And so we're really, really excited for this to get published, and it's going to be published in a matter of days if it's not already. So I'm super excited about that. We're going to hear more from Alyson here on specifics related to communication and language.
The interdisciplinary team that created this guide is a unique feature in this body of evidence. As identified by our Delphi participants, there are a number of statements that are provided by and agreed upon by the stakeholders that pertain directly to social emotional interactions and communication skills, which are seen on this slide. The numbers indicate the number of participants who identified these components related to social and communication development as an important part of teaching early powered mobility, such as the child feeling safe while in the device, the importance of allowing the child to exercise choice during the training sessions, using brief and simple language during training, identifying meaningful motivators and rewards for the child during training, engaging in various social situations with different people, and avoiding making demands or commands when providing the child with instruction. Because of the inarguable connections between motor and communication development, as well as the consensus from our stakeholders of the importance of acknowledging social and communication needs, throughout this guide, we have included specific evidence-based resources and strategies to enhance and support speech, language, and social development while learning early powered mobility. This is both in and out of the device and should be used throughout a child's daily routine. A few strategies I want to bring to your attention are the following, which can be used both in and out of the device and during any stage of learning. These include using simple and consistent language to give directions, comment and label, and especially with labeling items of high interest and importance to the child. Label the child's attempts to communicate, such as naming their emotional reactions and the function of their gestures or actions, such as you want more, or you are excited, or all done. Use more statements than questions. Importantly, you should observe, wait, listen, and acknowledge any gestures, words, or sounds that they make. Essentially, talk a little less and listen a little more, and then repeat back their communication attempt to teach the early skill of imitation. Create opportunities for a child to initiate communication. So put some of their highly desired items out of reach, close a bag or a jar tightly that they can still see that there is something in there, or offer two choices. And finally, follow a child's lead and join them where they are. This is one of the most important strategies in early intervention, because where there is interest, there is attention, and where there is attention, there is learning. And this guideline is chock full of more evidence-based strategies to take into consideration. Again, a child may experience a range of emotions in or around the device, and it's crucial to respond promptly to a child's verbal and nonverbal communication, emotions, interests, and their tolerance. A caregiver's response to a child's expression of their emotion is the earliest form of conversational turn-taking and positive emotional support, and it's the foundation of communication and relationship building. Being aware of a child's emotional state also allows us to tailor interventions most appropriately so that we're really supporting the whole child. Finally, throughout the guideline and in the appendices, you'll find evidence-based resources and tools to help all team members support communication development while simultaneously teaching powered mobility, including a list of the first 200 words in standardized American English that are most commonly learned. This will help you know what type of language to use with the child. The communication matrix is included to help the intervention team determine how a child communicates and for what functions, which is crucial to helping the child feel safe and heard during powered mobility trials, as well as determine what motivates the child. And anybody on the team can use this, and it's a free resource online from communicationmatrix.org. The Westby Play Scale is included to help team members determine appropriate interventions for play based on a child's developmental level and their skills, such as how many toys they can use at the same time and what their play is showing about their developmental level. Motor skills are closely related to development of play, which is also critical for cognitive, social, and communication development. Resources from the Hannon Center are also included to maximize communication between caregivers and therapists and children to maintain positive relationships with the child and provide them with opportunities to grow their language and communicate with a greater sense of agency. And you can find those at the link shown on this slide. We sincerely hope that you gain a great understanding and appreciation of the utility and necessity of an interdisciplinary team while introducing early powered mobility to the children and families that you serve. We hope that you utilize these resources that are made available to you in this guide to begin a dialogue with your team, to understand your client's needs more, and to provide more targeted and beneficial interventions. If you don't currently have a team, begin to use some of the listed strategies in your interventions while you start to reach out to other professionals in your area for more comprehensive assessment and treatment.
You see why we were so excited to have an amazing speech language pathologist on our team. Alyson is just incredible. So to wrap up here, a few implications on a couple of different levels. Again, we hope that this is a starting point, a way that we can further these discussions, further some of the considerations, and really push the envelope in terms of what we're designing and how we're introducing. So in terms of clinical practice and education, we think that this has the potential to provide, it's a peer-reviewed best practice, interprofessional approach, and offers a broad spectrum and approach to training. We hope it can help provide a common language, that it can suggest an aspect of consistent outcome measurement and tracking of device use for kids and families. Again, this is applicable to the Explore Mini and was designed with the Explore Mini in mind, but also other and future powered devices, perhaps switch activated devices that maybe kids in the GMFCS levels 4 and 5 could potentially engage with. Although we've had some recent success with a couple of kids in those levels with the Explore Mini as well. In addition, we hope that this becomes applicable to various contexts and countries, allows for individual adaptation based on client and context specific needs, and again lays the groundwork for future development and future improvement on what we've developed here. In terms of caregivers, it really stresses the collaborative partnership approach where the child and the family is at the center. It is something that can give families consistent language and vocabulary for discussion. It offers an ability to advocate as a family, but then also to have a conversation with clinicians or researchers about the information. We were really excited that caregivers were able to give key input to the guide. And so we are excited to see that again, just grow even more in the future. It doesn't require any special training or equipment. Whatever powered mobility equipment is right for you, the strategies in this guideline are really going to hopefully be useful across contexts. Oops. And finally, implications for research, right? It again reframes this collaborative partnership approach to research involving stakeholders at all levels. We adopted this through a biopsychosocial relational lens in terms of considering disability. And so we hope that comes through. We hope that it supports future grant funded research and multi-site studies to maximize self-initiated mobility and exploration outcomes. And we think that, again, gathering bigger data is only going to grow increasingly more important. And so we want to be systematic about how we stage and apply our training interventions and how we measure that and report that so that we're valued for the work that we do and the work and the opportunities that these kinds of devices provide. In addition to, of course, funding more research and providing guidance for students with projects and such. Just wanted to really quickly just give a huge thanks to Karin and Jenith from Permobil, who have just been supportive of us every step of the way. Our international Delphi participants, especially our caregivers, our expert review panel, Debbie, Lisa, Roz, and Lisbeth, and all of our amazing colleagues who have really helped pave the way for this work. We're really, really excited that the guideline is out and it's available. And I'm going to put the website in the chat. It is live, it is posted, and we really want you all to help continue to provide feedback, continue to disseminate, and continue to develop the next version. So please get in touch with us to continue the discussion. So we have a couple of minutes for questions. I know that Karin is here from Permobil as well. So, between the three of us, we're happy to answer any questions you might have or continue the discussion as the session wraps up here.
Heather, if I might just add that we are doing a webinar on February 9th. There are 3 times for that, and I don't know if we have the link listed anywhere, but if you check Permobil. Thank you very much. You beat me to it.
No, keep going. I just don't think I had advanced the slides enough. So
no, that was it. That was all I wanted to mention. That if you're available, please join us on February 9th for the full guideline. Any questions that we can address?
I think there were some questions for you.
There were. As I was monitoring the chat, I found 4. One of them was already answered. It was, where could we get a copy of the guide? And you provided that website. The first one was, how can we adapt for kids at the GMFCS5 or low centile 4 or SMA? What tricks do you have? And can we use a head array or other drive methods?
I'll take a moment to answer that. The device is not aimed at being able to be modified for any specific individual. It does not, it was not built for modification. It was not built for head array. And there's lots of theoretical and physiological reasons why that is. And we certainly don't have the time to get into that now. And the same thing with why not a switch, why a joystick. And I don't know if Karin wants to address that, but that would be a lengthy discussion that we would be happy to have with anybody offline.
What I will say though, in addition to that, is that there are places in the guide where we do talk about, switch in addition to joystick access. When we talk about, discovering the optimal access method, right? And so I do think that, our impetus for designing this guideline was, in response to the release of the Explorer Mini, right? But there are other devices, there are going to be future devices that strategies within this guideline in terms of head array, in terms of switch access, all of that there's a lot of it in here that will still apply, even though our impetus, our focus was mainly the Explorer Mini here.
Yeah, good point. Thank you.
So if I can just jump in for a second, I know we're at time. For people who have to jump off, I just want to provide the CEU code. I am pasting it into the chat as well. It is UZQ5LP. And again, that's posted into the chat. Thank you so much, our presenters. This was a great session. And if people want to stay on, you are welcome to stay on and chat, but I know some people have to jump off. And don't forget, there's a poster session coming up at 5 o'clock. Thank you all so much.
Thank you, Julie.
Thanks, Julie. And thanks to those of you who are posting the updated link.
Yeah, we're still available if anybody wants to stay for any questions or chat. Thank you, Jenna.
Good job. Good to hear from you guys. Sorry, the first link was an error. Hopefully we got it right.
No
We
worries.
can
Yeah.
chat for hours.
Yeah.
Right?
Yeah, you know us.
Dennis, weren't you in another session at the same
Yeah,
time?
we finished it with 20 minutes left.
Oh my gosh.
Oh,
Yeah, that was
Wow.
fun. Never a
I'm
dull
glad-
moment.
That is
Glad-
amazing. I'm going to write down the code before I'm writing them on my board as I go here.
no, I'm taking pictures
Right.
if you miss it.
Yeah.
Oh, well, I guess we shouldn't talk in this channel since the recording is still on and will remain for a year.
Bye, everyone.
Thank you all
so-
for being here and for all of your support.
Yeah, absolutely. Thank you
Thank you.
for
We'll-
staying